Coronary artery disease. Coronary artery disease (CAD) is characterized by the accumulation of fatty deposits along the innermost layer of the coronary arteries. The fatty deposits may develop in childhood and progressively enlarge and thicken throughout the lifespan. The enlarged lesion, atheroma or plaque, can cause a critical narrowing 75% of occlusion of the coronary artery lumen, resulting in a decrease in coronary blood flow and an inadequate supply of oxygen to the heart muscle. Pathophysiology and etiology. The most widely accepted cause of CAD is the accumulation of lipids, mainly cholesterol, and fibrous material, smooth muscle cells, within the coronary artery lumen. Increased blood levels of low density lipoprotein LDL, known as the bad cholesterol because it transports cholesterol to body tissues, irritate and damage the inner layer of the coronary vessels. LDL enters the vessel after damaging the protective barrier, accumulates and forms fatty streaks. Fatty streaks are yellow, flat, and cause no significant coronary artery obstruction. These lesions develop frequently between the ages of 8 to 18 years. Smooth muscle cells from the middle layer of the coronary artery move to the inner layer to engulf the fatty substances, produce fibrous tissue, and stimulate calcium deposition. This cycle continues, resulting in the transformation of the fatty streak into a fibrous plaque, and eventually a complicated CAD lesion evolves. A complicated lesion develops as small blood vessels grow into the fibrous plaque and the core of the lesion enlarges and calcifies. The complicated lesion can cause significant coronary obstruction by hemorrhage and ulceration of the plaque. Risk factors. The three major risk factors include high blood cholesterol levels, hypertension, and cigarette smoking. Unmodifiable risk factors include age, male, sex, race, and family history of coronary artery disease. Other risk factors include diabetes mellitus, obesity, sedentary lifestyle, and stress. Research is being conducted to explain the association of other factors such as chlamydial infection, increased homocysteine levels, hypothyroidism, and lipoprotein in the pathogenesis of atherosclerosis and CAD. Clinical manifestation: chest pain. Thoroughly evaluate any complaint of chest pain. Be alert to those highest risk for myocardial infarction: smokers, those with hypertension, those with hyperlipidemia, but do not discount that MI may occur in those without risk factors. Be alert to common alternative presentation of coronary artery disease and MI in women, diabetes, and the elderly: nausea, indigestion, fatigue. Notify healthcare provider and obtain ECG for any complaint of chest pain. For chest pain not relieved by rest assist, advise patient to go to emergency facility immediately. This information should serve as a general guideline only. Each patient situation presents a unique set of clinical factors and requires nursing judgment to guide care, which may include additional or alternative measures and approaches. Chest pain may be mild or severe. Stable or angina pectoris or unstable angina pectoris or silent ischemia attack can occur. Diagnostic evaluation: characteristic chest pain and clinical history. Second, nitroglycerin test, relief of pain with nitroglycerin. Third, ECG stress testing, progressive increases of speed and elevation of walking on a treadmill increase the workload of the heart. ST and T wave changes occur in myocardial ischemia is induced. Fourth, radionuclide imaging, a radioisotope Thallium-201 injected during exercise is imaged by camera. Low uptake of the isotope by heart muscle indicates regions of ischemia induced by exercise. Images taken during rest show the reversal of ischemia in those regions affected. Fifth, radionuclide ventriculography, gated blood pool scanning. Red blood cells tagged with the radioisotope are imaged by camera during exercise and at rest. Wall motion abnormalities of the heart can be detected and ejection fraction estimated. Sixth, cardiac catheterization. Coronary angiography performed during the procedure determines the presence, location, and extent of the coronary lesions. Seventh, positron emission tomography PET. Cardiac perfusion imaging with high resolution to detect very small perfusion differences due to stenotic arteries, not available in all settings. So diagnostic evaluations, first clinical history, nitroglycerin test, ECG stress testing, radionuclide imaging, radionuclide ventriculography, cardiac catheterization, positron emission tomography PET. Management, drug therapy. Anti-anginal medications, nitrates, beta blockers, calcium channel blockers are used to maintain a balance between oxygen supply and demand. A reduction of the workload of the heart decreases oxygen demand and consumption. Coronary vessel relaxation promotes blood flow to the heart muscle, thereby increasing oxygen supply. Nitrates can be administered orally, sublingually, transdermally, or IV and provide short or long-acting effects. Second one is beta blockers. Third, calcium channel blockers. Fourth, anti-lipid agents. Percutaneous transluminal angioplasty. A balloon-tipped catheter is placed in the coronary vessel narrowed by plaque. The balloon is inflated and deflated to stretch the vessel wall and flatten the lesion. Transluminal coronary angioplasty, that is PTCA. Blood flows freely through the unclogged vessel to the heart. Another one is intracoronary atherectomy. A blade-tipped catheter is guided into coronary vessel to the site of the plaque. Depending on the type of the blade is either cut, shaved, or pulverized and then removed. Requires a larger catheter introduction sheath, so its use is limited to larger vessel. Intracoronary stent. A diamond mesh tubular device is placed in the coronary vessel. Prevents restenosis by providing a skeletal support. And fourth one, coronary artery bypass surgery. A graft is surgically attached to the aorta and the other end of the graft is attached to the distal portion of the coronary vessel. Bypasses obstructive lesions in the vessel and returns adequate blood flow to the heart muscle supplied by the artery. Transmyocardial revascularization. By means of laser beam, small channels are formed in the myocardium to encourage new blood flow. Lifestyle modification. Cessation of smoking, control of high blood pressure, lowering of blood cholesterol level, dietary modifications, folate and B complex vitamins for hyperhomocystinemia. HYPER HOMOCYSTINEMIA. Hyperhomocystinemia. Complications. Sudden death due to lethal dysarrhythmias, congestive heart failure, and MI, myocardial infarction. Thank you.